Hey guys, this is Dr. Joel coming at you with another video. This time we're going to talk about atropine. Atropine is a very high yield topic. You're definitely going to get some questions about it or about related topics, so you kind of need to understand this. In this video, I'm going to give you a quick summary of the drug, then I'll talk about the mechanism of action, the clinical uses, the side effects, and all those are going to kind of blend together by the end, and it'll just make sense. And then we're going to have some knowledge challenge questions at the end. If you haven't seen my videos before, they're highly interactive, so there's links all over these videos to take you to different places within this video or different places in other videos. Okay, let's get started. Okay guys, so the therapeutic or pharmacologic class of atropine. There's a couple different words here that we're going to go over. Atropine is an antimuscarinic agent. It's also sometimes called an anticholinergic agent and less frequently a parasympatholytic agent. What do those terms mean? What the heck are they talking about? Well, antimuscarinic refers to the fact that atropine blocks the muscarinic receptors. Anticholinergic refers to the fact that atropine blocks the effects of acetylcholine on those muscarinic receptors. Does that make sense? So one of these terms is referring to the fact that atropine is blocking the receptor, and the other term is referring to the fact that atropine is blocking a neurotransmitter on those receptors, right? So the muscarinic receptors and acetylcholine. Parasympatholytic is a term that describes kind of the overall physiologic response of atropine. It's basically blocking the parasympathetic nervous system, which is covered here in the next couple bullet points. So it's almost like the summary of action is that this drug acts as the opposite of the rest and digest or parasympathetic nervous system. Now, you need to be careful because the opposite of the parasympathetic response is not directly equal to an increase in the sympathetic response. It might look the same in some ways, but physiologically it's not exactly the same. Okay? What you get out of that is the relaxation of some kinds of smooth muscles, which we'll talk about. Also, you get a decrease in secretions. Also, you get an increase in heart rate because you're decreasing the parasympathetic tone to the heart. We're going to cover this in the next section. So let's just move on and talk about the mechanism of action. And I think a lot of this will make more sense. Okay? All right, so atropine is a non-selective, competitive, and reversible muscarinic receptor antagonist or blocker. Because it's non-selective, it works on the M1 or muscarinic 1, 2, 3, 4, and 5. And these receptors aren't really easy to remember all the time. So if you click on this link over on the right here, you will be taken to another video that talks about the cholinergic receptors, including these muscarinic receptors, and maybe that will help you understand them a little bit better. Well, I'm going to draw this out pretty superficially. On the left hand here, I've got the autonomic nervous system, and on the right, for comparison, I've got the somatic nervous system. So, this top set of arrows here under the autonomic nervous system are the preganglionic neurons. What neurotransmitter are they using or are they releasing? It's acetylcholine. What are the receptors that are receiving that acetylcholine? Well, in both cases, this is nicotinic. It's the same on the somatic nervous system side. These are nicotinic receptors receiving or sensing acetylcholine. This second set of arrows represents the postganglionic neurons. In the sympathetic nervous system, what receptors are we looking at on the target organs? Well, for the sympathetic system, it's going to be adrenergic receptors. That makes sense, right? And on the parasympathetic nervous system, here's the key, muscarinic receptors. So adrenergic neurotransmitters work here, and acetylcholine works in all these other places. But because atropine blocks the muscarinic receptors, we don't really have any effect on the nicotinic receptors or any of these other systems, just on the target organs of the parasympathetic nervous system. See how that works? Pretty cool, right? So let's next talk about what a few of the specific muscarinic receptors do. I am not going to cover all 5 of them just because they're not all high yield. I'm only really going to cover the M2 receptor and the M3 receptor. If you need to know what the others do, that's totally cool. You can follow that link, that previous link I gave you to the anticholinergic receptors video, which I think is a pretty good video. Or you can look it up in your textbooks. It's just not high yield for a review video like this. So, M2 antagonism or M2 receptor blocking, what does that do? What does that look like? Well, you need to ask yourself, where in the heck are all the M2 receptors? Or not all of them, but a lot of them. And the answer is in the heart. There's a lot of M2 receptors in the SA or sinoatrial and AV or atrioventricular nodes, which, what do they normally do there? Well, they're normally sensing parasympathetic tone from the vagus nerve. So if we block that calming, soothing, and warm signal from the vagus nerve, what's going to happen? Well, all the heart's going to have left is the angry, screaming noise from the sympathetic system and nothing to counteract that. So your heart rate is going to increase through the SA node. The conduction velocity will increase partially through the AV node. So your heart's going to beat faster, quicker, right? That makes sense. Next important point on the M2 receptor. It works through the GI pathway, which, if you click on the link here, will take you to a good video on the G protein receptors. I'm not going to cover that here. It's a little bit out of the scope. But unfortunately, the the G protein receptors, they are high yield for your boards. You do need to know them. So if you've got no idea what GI means, well, then you should probably go watch that video, okay? I'm sorry for the extra work, but you got to know it. You just have to know it for your boards. Okay, let's move on. Next up are the M3 receptors. What happens when we block these M3 receptors? Well, the key here is, again, where are M3 receptors? Well, there's a whole lot of them associated with smooth muscle and a lot of them associated with exocrine glands. So, if you decrease the smooth muscle functioning in the GI tract, remember, this is the rest and digest, or the parasympathetic nervous system. So if we decrease that tone, well, you're going to have decreased peristalsis, which could lead to constipation. You could also have a decrease in the tone of your bladder, which could lead to urinary retention. There's effects in the eyes, mydriasis, which is the dilation of the pupil, and cycloplasia, which is paralysis of the ciliary muscles, which act to change the shape of the lens. So you lose accommodation. You can't focus on things. And bronchodilation. For the exocrine glands, you can see that there's some GI stuff there. You're decreasing GI secretions. Again, that leads to constipation. When your bowels are dry and they're not moving, I mean, that could be a problem, right? Here's a big one, decrease in salivation. This is important. It's actually one of the uses of atropine. Sometimes surgeons use this on purpose to decrease salivation when they're working in the throat or the mouth, or they just want to decrease the amount of goopiness, I guess, the amount of liquid in your mouth, okay? We can decrease bronchial secretions and also decrease sweat, which will come into one of the side effects in a minute. The M3 receptors work on the GQ pathway. High yield, remember that, don't forget it, okay? Let's move on. As for the clinical uses, we've kind of talked about a lot of these, and so we're going to see some overlap here. Hopefully it's intuitive. Obviously, if someone is having symptomatic bradycardia, atropine is a drug that you could use. In fact, it is in the ACLS protocol, and because it's something that could be an emergency situation, you should know it, and you should know that it's 1 milligram IV push every 3 to 5 minutes or every cycle in the ACLS protocol for a maximum of 3 milligrams, all right? Also, you might get asked or even see a patient who has some cholinesterase inhibitor poisoning Atropine is an antidote for that. What you're more likely to see is insecticide, like a farmer or a county mosquito worker being poisoned with their own insecticide. But what you're more likely to be pimped on is a nerve gas poison or a nerve agent. So what is a cholinesterase inhibitor? Well, a cholinesterase is an enzyme that breaks down acetylcholine. And it does that because we're constantly producing acetylcholine. So there's this balance between production and metabolism. Well, obviously, if you decrease the rate that you metabolize acetylcholine with this cholinesterase inhibitor, well, then you're going to get this runaway, kind of like an explosion of acetylcholine, and that's going to start pinging on your nerves really hard, and that can cause a whole lot of symptoms. And in fact, those symptoms are high yield, and so I'm going to just kind of give those to you right now. I think this is a worthy tangent because it's also high yield. Those symptoms you can remember by the mnemonic dumbbells, which stands for the following symptoms: diarrhea, urination, meiosis, bronchospasm, bradycardia, excitation of skeletal muscle and the CNS, lacrimation, sweating, and salivation. So that's the dumbbells mnemonic for cholinesterase inhibitor poisoning. That's what it would look like to be poisoned with this kind of poison. And as we've already talked about, atropine is almost exactly the opposite of each of those, okay? Historically, atropine was used in some ophthalmic procedures, not so much anymore because there's better agents. If you put a dropper of some atropine in someone's eyes, the problem with it is that it would last for like 3 days. Your patient would be walking around with their pupil dilated and their ciliary muscles paralyzed, and they wouldn't be able to focus, they wouldn't be able to see, they'd be sensitive to bright lights, it would be uncomfortable for like 3 days. So not a great drug. We've got better drugs that work quicker. Also, drug-induced AV block is a potential use of atropine. And then any situation where you need to decrease the motility of the GI tract, or if you need to decrease the urge to urinate. Now, we're not changing the amount of urine production, but just if someone has a leaky bladder or they're incontinent, you could use atropine. Again, there's other drugs that work more specifically or that are better than atropine, but you could use it. Now into the side effects for atropine. And you know what's cool about pharmacology? The cool thing I think about pharmacology is that once you start to understand a drug or the mechanism of action or the physiology, everything else just kind of fits into place, right? This slide is on the side effects, but we've talked about these already, haven't we? In the mechanism of action, we learned about why you're going to have decreased salivation or why you're going to have blurred vision. It makes sense. So a couple of the side effects that we haven't talked about that you might get asked. For one, how about this? Hyperthermia. Why might you have a problem with being too hot? The answer is mostly because you're not going to produce as much sweat. And sweat is very important for thermoregulation. How about delirium? Hallucinations. Well, these side effects are from some of the receptors that we haven't talked about. Remember how we only covered really just the M2 and M3 receptors? Well, if you consider some of the other receptors, they have high concentrations in some of the CNS. So like the M1, M4, and M5, and even a little bit of M3. High doses of atropine could cause delirium and hallucinations. So that's where that side effect comes from. And the others, well, we've talked about them and they make sense. There is a very common mnemonic which says hot as a hare, dry as a bone, red as a beet, blind as a bat, mad as a hatter, bloated as a toad. Basically, that's all the side effects of atropine. Hot, hyperthermia, dry as a bone, your secretions are down, red as a beet, you're flushing in your skin, blind as a bat, obviously your eyes, you can't see, mad as a hatter, talking about the delirium and hallucinations, and bloated as a toad, speaking to your urinary tract and also your GI system. Okay? Congratulations, you guys. You have hung in there all the way to the end. Knowledge challenge number 1. You are a student at an urgent care, okay? A 45-year-old male patient comes in to see you, and he's in severe respiratory distress. His coworker says that he was exposed to a large amount of malathion, which is an insecticide, specifically an organophosphate insecticide. You know that this is a cholinesterase inhibitor. And you also know that atropine could be used as an antidote. But knowing your physiology, because you're so sharp, what other symptom is he likely experiencing out of this list? Drooling. B is the correct answer. Why not constipation, tachycardia, or mydriasis? Well, remember, when you're talking about cholinesterase inhibitor poisoning, you're talking about a runaway reaction of the parasympathetic nervous system. Atropine blocks the parasympathetic nervous system. Remember, it's a parasympatholytic. It blocks that. So that knocks out constipation, tachycardia, and mydriasis. Do you guys remember the mnemonic that I gave you to remember the symptoms of being poisoned with a cholinesterase inhibitor? That mnemonic was dumbbells, diarrhea, urination, meiosis, bronchospasm, which is why he presents to your clinic. He's having a hard time breathing. That's probably not enough on its own for him to have his severe respiratory distress. Maybe he had some reactive airway on top of that. Bradycardia, excitation of skeletal muscle and CNS, lacrimation, sweating, and salivation. Okay, he's just drooling all over himself. Lots of bronchospasm, a lot of secretions in his airway, and a lot of salivation. And he's just gagging and coughing, and he's turning blue on you. Okay, so anyway, if you picked drooling, good job. You win first prize. Knowledge challenge number 2. Yeah, you made it this far. Good job, guys. In the case of a nerve agent attack, acetylcholinesterase enzymes are deactivated by phosphorylation by the poison, the nerve gas, the nerve agent. This causes an increase in the amount of acetylcholine available, right? Because it's not being broken down. And acetylcholine acts as a neurotransmitter, which leads to the overstimulation of the cholinergic linked systems. And this is how it poisons you. Atropine can reverse the physiologic effects, but which of the following agents can restore the acetylcholine esterase or the cholinesterase function? We didn't talk about this directly. It's a little bit of a harder question. The answer is C, pralidoxime or 2-PAM. So what happens is that the acetylcholinesterase or the cholinesterase inhibitor binds itself to the enzyme, thereby blocking the enzyme's function. Pralidoxime can come in and unbind the inhibitor and allow the enzymes to work again, so you kind of restore function. However, you need to give this agent fairly quickly because if the enzyme and the inhibitor are allowed to remain bound long enough, there's a process called aging, and the bond becomes irreversible, or 2-PAM wouldn't work anymore. So this is something you have to give pretty quickly. What is penicillamine? What does it do? Well, it's a chelator. It's a chelating agent. It's normally used for copper or to get copper out of the system. People use it in like Wilson's disease, things like that. How about benztropine? Well, benztropine is another muscarinic antagonist, kind of like atropine, but it's used mostly for like Parkinson's disease. What about pyridostigmine? Well, that would be wrong because pyridostigmine is actually itself an acetylcholinesterase inhibitor, but we use it as a medication for things like myasthenia gravis, okay, to help boost the nervous system, okay? Anyway, if you picked 2-PAM, you're the winner. Good job. Hey guys, thanks so much for watching my video. I love making these things for you. I am a resident, so I'm a little bit busy, but shoot me a comment. Let me know what you thought. I try and respond when I have time. Subscribe to my channel, that helps me. Give me a like, that also helps me. Here are some more links for you. The top blue links are within this video and the black ones go to other videos. If you're super awesome and you've got some spare change, you can leave a donation in the upper right corner. That helps me keep the lights turned on. It costs money to run a website. Otherwise, good luck in school. All right, you can do it. Hang in there. You're going to be great.